Hello, welcome to this video on examination and investigations in a patient with diabetes. So we diagnosed a patient with diabetes. We took the elaborative history. In the history, I'm just summarizing the previous video. In the history, the important aspect was diabetic history, where we ask about the diabetes symptoms and the medication history. What anti-diabetic medications the patient is on, if the patient is regular, if the patient is able to tolerate the medications or not. Apart from that, important part of history is the personal history, where you ask for sleep, appetite, bowel, bladder, habits, etc. If you're thinking in terms of type 1 diabetes or maturity onset diabetes in young, then you should also ask about the family history. If family have any diabetes, or if there is a family history of autoimmune or thyroid diseases. Now we have finished taking history. Now let's see what we should say in the examination. So the first important part is the pallor. Okay. In pallor, we need to check pallor for two reasons. So one is metformin. I have told this in diet also. So metformin causes vitamin B12 deficiency, and this in turn can cause pallor or megaloblastic anemia. The second reason is, glycated hemoglobin is an important test to control or to monitor diabetes. HbA1c. Iron deficiency anemia and megaloblastic anemia can falsely show elevated HbA1c levels. So B12 deficiency and iron deficiency anemia can show falsely elevated HbA1c levels. So when you're monitoring HbA1c, it's important that hemoglobin is in the normal range. If not, you should first bring it to normal range and then monitor HbA1c. Then BMI. BMI is very, very important. Normal BMI is 18.5 to 24.9, but in Asians, the higher limit is slightly towards the lower side. That is 18.5 to 22.9 kg per meter square is the normal BMI for Asians. What is the reason for checking BMI? There are two main reasons, okay? The first reason, you all know that it's an important risk factor for metabolic diseases. It's an important risk factor for metabolic diseases. The second reason is there are certain anti-diabetic medications which can cause weight gain. For example, can you tell me few examples for anti-diabetics which can cause weight gain? The first is sulfonylureas, your glimepiride, gliclazide, etc. Then the second is thiazolidinediones, rosiglitazone, pioglitazone, these. Then third, very important, is the insulin. These three anti-diabetic medications can cause weight gain. So if any of your patient is on these medications, even then the monitoring of BMI becomes very, very important. Okay. Then next is the blood pressure. So blood pressure, diabetes, blood pressure, they are the risk factor for stroke. So if a patient has diabetes, there are chances that the patient might also have blood pressure. So you should monitor their blood pressure. Also, the blood pressure target in healthy individuals is different, and in individuals with diabetes is different. So you have to maintain the target blood pressure in diabetics. Then you need to check heart rate as well. Then next important thing is the waist circumference. So the waist circumference is measured at a horizontal plane above the iliac crest. In this image, the iliac crest comes somewhere here. So just above the horizontal, it will nearly be at the level of umbilicus. So you will measure here at just in the horizontal plane above the iliac crest. This is what is the importance of waist circumference. Waist circumference is a surrogate marker for visceral adipose tissue. So if the abdominal waist circumference is high, it means that the visceral adipose tissue is also high. So this is an important risk factor for metabolic diseases. Imagine a patient is obese, the BMI is high. Because the BMI is high, he is more prone for diabetes or the metabolic diseases. In addition to BMI, if his waist circumference is also high, then this is his additionally the risk increases now for metabolic diseases. It's independent risk factors. For South Asians, the waist circumference more than 90 in men and more than 80 centimeter in women, it's a risk factor. Like if it's more than these cutoff values, then they are more prone for metabolic diseases. So remember the cutoff, it's more than 80 in women and more than 90 in men. Then signs of insulin resistance. You checked for all these, now you need to check for the signs of insulin. So you can remember it as 4 A's. Okay, let's see what are those 4 A's. The first is the acrocordons. So acrocordons is nothing but medical term for the skin tags. If you see an obese patient, there might be, can you see this in the image? These are the skin tags. This is the sign of insulin resistance. These are present in the areas of friction. Areas of friction. So in the OPD, where all you can see it around the eyes, okay, in the neck, and you can see it in the axilla. In the OPD, you can look for acrocordons or the skin tags in these areas. Then acanthosis nigricans. This is a, can you see this image? So there is a velvety texture, dark velvety texture in the areas of, in the flexural areas. Even acrocordons was present in flexural areas. Acanthosis nigricans is also present in the flexural areas. So this is a dark velvety texture. Velvety texture in, this is also present in the flexural areas. Then acne. Apart from that, androgenetic alopecia. These 4 A's, acrocordons, acanthosis nigricans, acne, androgenetic alopecia. These are the signs of insulin resistance. So the next very important thing is the foot examination. People with diabetes, what happens, they do not have their peripheral foot sensations are reduced. Therefore, they are more prone for wound, like infections or the wound in the foot. That is why foot examination is very important in diabetic patients. First, visual inspection. You should check for, it is done in the every visit. What all do you check? You will check for any cracks, any injuries or wounds. This should be done in every visit. Then what else you can check? Pedal artery pulsation, vibration sensation. You will be checking for all the sensation, vibration, touch, pain, reflexes, all these things. How do you check for vibration? You will take a 128 megahertz tuning fork and you will keep it at the base of great toe. Base of great toe. You should assess if the patient is able to feel the vibrations or not. Then touch sensation. If you go to any surgical shop or Amazon or any online platform, you will get 10 gram monofilament. You can test for the touch here. So touch it to the foot and see if the patient is able to sense it or not. Pinprick sensation. So you should check for this checks for the pain. This checks for the touch. And this is the vibration. You are checking all the 3. Then ankle reflex. So visual inspection is done during every visit and rest of these can be done annually. Okay. This is about the foot exam. Apart from that, you should also check for foot deformities. The common foot deformity seen in diabetics are hammer toe. Hammer toe is flexion at proximal intertarsal joint. Intertarsal joint. This is hammer toe. Then you should look for claw toes. This is proximal plus distal. There is flexion at both the joints, proximal intertarsal joint and distal intertarsal joint. Then Charcot's foot. So what happens in Charcot's foot? There is microvascular injury. Microvascular injury. Because of the microvascular injury, there is injury to bones. Bones are injured. Now the bones are injured, but in addition to this, there is also neuropathy in the patient. Because of the neuropathy, the body is unable to understand that the bones are injured. So the patient continues to walk on the injured bones. Because of this, there is final deformity in the bones, which is Charcot's foot. So did you understand? First of all, the bones are weakened, but due to neuropathy, the body is unable to understand that bones are weakened, and patient continues to walk on the weakened bones. And then finally, it leads to bone deformity. So this is image of a patient who came to my clinic. Can you tell me what is the deformity seen here? Let me encircle it for you. So here there is flexion at proximal or distal. It's at the proximal. So what is this? It is hammer toe. If it was both, can you see? Even here there is a flexion at the proximal intertarsal joint. Even here there is flexion at the proximal. Distal intertarsal joint is here. This is the hammer toe. Okay. Now investigation. You examine the patient. What all investigation will you do? Complete blood picture. This is very important. I told you the reason, right? So one is for the metformin reason. Metformin causes megaloblastic anemia. The second reason is for measuring HbA1c. To measure HbA1c, first hemoglobin should be within the normal limits. Otherwise, there will be falsely elevated glycated hemoglobin levels. Then HbA1c. So this is very important. It will give you the glycemic control of the patient for around 90 days. Some references say 120 days, some references say 6 to 8 weeks, but most of the references say 90 days. That is why I have told you 90 days. So it will be done during every first visit. Then if the patient sugar levels are controlled or stable, you can do it every 6 months. If it's uncontrolled or unstable, then every 3 months. Complete blood picture, glycated hemoglobin, fasting lipid profile. This is because first it is also a metabolic disease. All these three can be present in a patient. So you need to rule out if the patient is only diabetic or along with diabetes the patient has hypertension and elevated cholesterol levels also. For this you will do the fasting lipid profile. Apart from that, increased triglyceride levels can also give you false HbA1c levels. That is why you need to do the lipid profile. There are two reasons. Main one, to rule out dyslipidemia. Second, it can produce false glycated hemoglobin levels. Third, spot urine albumin by creatinine ratio. This is mainly to screen for nephropathy. Serum potassium. It will be done if the patient is on ACE inhibitors or ARBs. Then what else? So you can get it done depending on the paying ability of the patient. You can also get serum B12, calcium, vitamin D, and magnesium done. So, vitamin D and magnesium deficiency can be seen in diabetics. While doing vitamin D at least is very important for diabetes. B12, vitamin D, these are very important. Like if you are unable to get all the four done, at least get these and this done. Okay, so summarizing complete blood picture: glycated hemoglobin during the first visit and then every visit, fasting lipid profile, spot urine bar creatinine ratio, serum potassium if the patient is on AC inhibitors or ARBs, serum B12, calcium, vitamin D, magnesium depending on the paying ability of the patient. So all this HbA1c I told it will be done every visit. Then if it's uncontrolled, 3 months. If it's controlled, 6 months. Like more than control, I would say it's stable. Then remaining can be repeated annually. Once in a year is sufficient. Remaining are. Summary, I'll just tell you because first we check for pallor, then BMI because it's a risk factor and some antidiabetics can cause weight gain, blood pressure and heart rate, waist circumference, signs of insulin resistance. That were 4 A's. Can you tell me 4 A's now? Acanthosis nigricans, acrocordons or the skin tags, both of these are present in the flexural areas. Then acne and androgenetic alopecia. Then foot examination. Visual inspection is done during every visit, but remaining for the touch, for the vibration, for the pain, reflexes, they can be done annually. So that's it about the examination and investigations. Stay tuned for more.